Hi Preeti, hi Apurva. So we are going to be doing this most important chapter from ETG. I'm covering it from ETG because it includes all the latest TG lesions, and aside from that, it also includes the extra ones. So this is going to help us prepare the ones which are already there on the TG. Plus, it will also include the ETG newer lesions, and those lesions are new in the ETG, but they are not new to the examination. They have been getting asked in the exam already. You have been seeing and facing questions on them from the last many years in the ADC exam. But ETG including those lesions gives us a confident way of preparing them, and we also know that what answers exactly work for ADC. Absolutely not, Preeti, because we emailed the ADC and they said that unless they announce the existing version of TG will only be the standard of reference for the exam. All right. So for March, it would be TG3, but September, unless they announce, we can't really say. So the September candidates, you can continue to read TG3, and once it gets announced, I'll also record the TG4 classes. Fresh TG4 classes will be provided to the September 26th batch. All right. So till that time, we'll continue to do the TG3, which is the 2019 edition. All right. We have to see once it's released, Netra. Although the electronic copies are released, but the published copies are not yet. So once I get my hands on the electronic copy, then I would be able to tell what changes there would be. But I think all the ETG changes will be there. Whatever ETG has, the updates that came on the ETG, they would be also part of the TG4. So I think they are quite a lot of updates. So let's expect them. All right, so let's start preparing the oral mucosal disease. It's an extremely important chapter, extremely important concept, includes most of your oral medicine conditions that get asked in the exam, and what should be the approach to address such oral mucosal diseases. What it is extremely important, what you can handle and manage in general practice, and what is the indicator for specialist referral. Those are extremely important points. Is it clear now, Priyanka? Yes, the internet is quite unstable today. I'm really trying to make it work, and I hope it is working. Is it audible now? All right. So we are going to start with the general introduction to the oral mucosal lesions here. What are the basic causes? What are the basic etiological factors which leads to the oral mucosal lesions? And they are extremely important in your clinical dentistry when you start practicing wherever you're practicing, and when you start practicing in Australia. These would be kind of like your regular presentations in your patients. So they are extremely common, and that's why, as a general dentist, you must be aware of all the local diseases, skin conditions, and all the physiological changes which are associated with these oral lesions. You must be aware of all these features, and you should be aware of the drug reactions that can lead to that, systemic diseases that can lead to that. And if you are aware of the possible causes, the physiological changes, or a local condition, or a skin condition which has an oral manifestation, sometimes a reaction to a drug can also cause that, or any systemic condition like a GI disease, which can give you the oral manifestation. If you know the basic causes, then your diagnosis will become more accurate. And that is why the successful management will follow. If your diagnosis is not accurate, then your management cannot be successful. And especially when there are red flags present, identifying the red flags and making timely referrals so that the oral cancer malignancy can be ruled out. That can affect the overall outcome of the patient's condition, right? So, does that make sense? The 5 learning points here are your underlying possible etiological factors which are associated with oral mucosal lesions. There can be physiological changes in the oral mucosa. Local disease can lead to that. Skin conditions which can have oral manifestations, adverse drug reactions, and systemic diseases. So out of these 5 broad categories, one of the category would apply to your mucosal lesion. Okay? So when the patient presents to you and there is a presented oral mucosal lesion, you must get the patient's complete history, including their medication history, because there are adverse reactions to certain drugs which can lead to these oral findings. Other than that, you will perform an extraoral and intraoral examination as well, full patient's history, thorough examination, and you will ask questions which will give you the nature of the lesion, which will help you with the diagnosis. So the most important questions are here in the red. As you can see, these 5 important information gathering questions. These are your examination concepts. Duration of the lesion, because duration of the lesion is associated with red flags. Is it or is it not? Any oral ulcer that have lasted for more than 2 weeks is a red flag. Can you write it down? Put it in your notes. Any oral ulcer lasting more than 2 weeks is a red flag. Now, whenever you see an oral lesion question in exam, your immediate senses should work on, let's find out if there are any red flags. Because the moment you find any red flags, your answer for the management immediately changes to referral instead of managing yourself. Does that help? Does that make sense? That is your immediate answer to management questions, you know? So when you train your brain to attempt such questions and you know in sequence how you have to think. If you are enrolled with me, you're doing internal classes with me, I have been training you to even sequence your thoughts. You know that, right? Because with certain questions, there is a particular sequence of thought that you have to apply to arrive to a correct conclusion. If you are not thinking correctly, it will affect your final answer, right? We have been applying that to our UAF2 questions or not? What should be the correct sequence of thought which can lead to correct answer? If your thought process is not correct, if your critical thinking is not correct, it would lead to incorrect answers. So if you're looking at the wrong places, wrong keywords, and not knowing what to find, you can miss out on the question. So what you should be focusing on is the duration of the lesion, because 2 weeks or more is a red flag, and red flags requires immediate referral. What are the precipitating factors? Trauma or burns? Get the causative or precipitating factor. Then what are the symptoms? What kind of pain? Any other symptom, if it's painless, they will also help you determine the diagnosis. What are the relieving factors? What are the exacerbating factors? And what are the other changes which are associated with the lesion? All these questions are extremely important to be asked from the patient, and always consider a possibility of oral cancer if the patient has the risk factors. So all this will not be presented to you in the exam as given, okay, this patient has lesion which lasted 3 weeks, it is a red flag, what will you do? They are going to retain information from you to some extent and give you only limited information, and they would require you to think. If the duration is greater than 2 weeks, then it's a red flag. Or if the patient's age is 50s, 60s, it's an elderly patient. Is it a risk factor for cancer or not? So any oral leukoplakia and a patient's age is 60s or 50s, you should suspect oral cancer. So patients with risk factors require to be also considered, that the lesion should be considered that could be a oral cancer. So there are certain lesions which, provided that they do not have any red flag, so you have to still, even if these conditions are given to you in the history, now make this very important note everybody, and give me yes and no's if it's coming together and making sense to you. Okay, I need some yes and no's to understand that you all are understanding, because I want you to learn the chapter while we are doing the lectures. Okay, I don't want you to go back to the lecture and then see, oh yeah, that was the concept. I want you to learn the concept right away. So this list that you see here, unless there is a red flag attached to it, it can be easily managed in general practice, because these are mostly your non-malignant conditions. Okay? But there can be certain conditions which would require specialist referral. They would be your associated with red flags, or there are certain non-malignant conditions which I'll tell you about in the next few slides, which would also require specialist referral. So not just carcinomas always require referral. Understood? One learning point. It's a keyword, a key concept here. It's not only cancers which require referral. Certain non-malignant conditions also require your referral. Can anyone here on the meeting can tell me what non-malignant condition can also require specialist referral? Your lichenoid reactions, right? Recurring oral ulcers, non-traumatic ulcers present in children, right? Dry mouth, which is not getting relieved by any over-the-counter products, and any other systemic conditions like syphilis, Behçet syndrome, HIV, oral hairy leukoplakia, inflammatory bowel disease, lichen planus and pemphigoid and pemphigus. These are all non-malignant conditions. Is that right? All the conditions that we just talked about, they're non-malignant one, aren't they? But do they require specialist referral? Yes. So these are the conditions which are in the general dentistry scope. All the red flags are in the specialist scope, and all the non-malignant conditions that I just mentioned are also specialist scope. Is that clear in your, now the mental picture is clear or not? Yes? So there are three categories of lesions. One is this, without any red flag, these conditions are general dentistry. All the red flags, even if these conditions plus any red flag becomes a specialist condition. And all the non-malignant conditions which I just mentioned, lichenoid lesion, oral ulcers which recur, non-traumatic oral ulcers in children, dry mouth which is not getting relieved with your management, and syphilis, Behçet's, lupus also, oral hairy leukoplakia, inflammatory bowel disease, lichen planus, pemphigoid. All those are your specialist lesions. They are not cancers, but they are specialist lesions. Clear for everyone? So three categories. Now, in the exam, when the patient presents, once you make a provisional diagnosis, everybody knows the UF2 internal class rule to make a provisional diagnosis, right? Once upon the history, upon reading the history, you create a provisional diagnosis. Either it would be one of these, or it would have a red flag, or it would be one of those benign non-malignant conditions. Is that correct? It would be one of the three categories. Red flag would make it suspicious for oral cancer, so specialist for cancer rule out. Just these lesions without red flag under your scope. You will choose the answers which talk about active dental treatment, active treatment. And the non-malignant lesions, which I just gave you the list, which are not necessarily red flag, which are not these benign conditions, but they are benign, they're not cancerous, but they are out of scope of general dentistry. Is that clear for everyone? The concept is learned, understood, absorbed or not? Tell me now. Now that is the summary of this entire chapter. Is it or is it not? So now in this chapter, you would learn to manage these conditions yourself. Question in the exam, you will be given either these conditions. So your investigations will be asked, or your information gathering will be asked, your management and diagnosis questions will be asked, and treatment and evaluation will be asked. But you know that these are the treatments which you would be providing. Then there would be histories in the exam which would include any of these conditions, but they will throw in the red flag. So they want you to be smart enough to identify the red flag and make an immediate referral. Would you be smart enough in the exam to catch that or no? Yes or no, please. I want you to step up here and own this chapter, that you can completely rule this, completely master these questions. Sounds good, right? Does it give you a bird's eye view or not? That this entire chapter is about ADC wanting you to know what comes under what category, how to diagnose, reading the history, how to find out red flags, how to find out what are the benign or non-malignant lesions which require referral. So Priyanka, not any mild dry mouth, but dry mouth which is not responding to the treatment, that gets referred, right? HIV's conditions like chronic oral oropharyngeal candidiasis, any candidiasis which is going up to the pharynx. General oral candidiasis not, but any candidiasis which is going up to the pharynx, that indicates HIV, so that will go for referral. Non-traumatic ulcer, not in adults, but non-traumatic ulcers in children. So your list is almost there, but incomplete. Okay, I'm going to show you the list, Priyanka. Don't worry, we're going to come to that slide. But I wanted to give you a complete bird's eye view of this entire chapter, and I think you got that, everybody. Right? So what you can handle yourself without any red flag, you can handle mild recurrent aphthous ulcers. You can handle traumatic oral ulcers where there is a clear-cut indicator of trauma and there is no red flag. So any traumatic ulcer which has a red flag, you can do immediate management there. You can remove the source of trauma in that appointment. But referral is important and immediately important. So if you have two options given, it's a traumatic oral ulcer history and there is a red flag option given, and there are two separate options given in treatment, that you would remove the source of trauma and the other option is you will refer to the specialist. Which one would you choose? So traumatic oral ulcer with red flag present, that's the wrong answer, Asta. If you have, I have given you two separate options here. Exam will give you different options. There are third possible option. So I'll give you three possible options now. It's a traumatic ulcer with red flag. You remove the source of trauma. First option ends there, period. Second option, you would make the referral, period. Third option, you would remove the source of trauma and immediately refer. What's your best choice here? Now you refer. Now you remove the source and then refer. But suppose the third option is not given, then sequence it, apply the rash, which is the second best option. Option B, absolutely correct. Asta, you got your answer. When the red flag is present with the traumatic ulcer and combined of removal the source of trauma and referral is not given, then sequence it. Your second best option is immediately refer and not treat the trauma because of the red flag. Okay, everybody got it? And only in the absence of red flag you will treat the traumatic ulcers in your clinic. These are your clear-cut examination questions, and I have seen those questions in the last many years with so many variations, and I'm giving you here the golden rule to apply and simply get to the exact accurate answers in the exam. Take away all the guesswork out of your preparation. With the power sessions, I give you the techniques, I give you the methods. Sure shot hits the bullseye. Okay? That is exactly the kind of preparation you need for this examination. No guessworks, no thinking, no time wasted for extra thinking. These are your core concepts. Okay? Then, angular cheilitis. Angular cheilitis is repeatedly asked in the exam with your reduced video. Yes or no? Oral candidiasis. It can also be associated with denture stomatitis, hyperplastic type, right? Pseudomembranous type. Again, scope of general dentistry, but given that red flag should not be present. That's why in the history, always look for the red flag. But in Mega Master, in Ultimate Advanced File, in UF2, You have seen so many questions on oral candidiasis and angular cheilitis. We are practicing so much how to investigate, what are the clinical presentations, what are the treatment and evaluations. In this chapter also, the oral mucosal lesion include the management of all of it, and we will slowly cover one by one every single lesion. Now, oral mucocutaneous viral infections without immune compromise, shingles, herpes, right? Herpetic stomatitis, they are all your oral mucocutaneous virus infections? Yes or no? Right? Recurrent herpes labialis, absolutely correct, Priyanka. We're going to come to that. So, if there are no red flags present and the diagnosis is straightforward, you can manage it in your general practice. Mild dry mouth, oral mucositis. What leads to oral mucositis? After radiotherapy. You can manage it, very well manage it. Amalgam tattoo, you can manage it. Geographic tongue, no red flags should be present. You can completely deal with these conditions. Hairy tongue, do not mix the hairy tongue with oral hairy leukoplakia. Now, oral hairy leukoplakia is not in this list. Oral hairy leukoplakia comes in the list of non-malignant conditions which require specialist referral. Yes or no? Because they are the indicators of HIV. Absolutely correct, Jasmine. Beautiful. Everybody, is it making sense? Beautifully coming together. Broadly, which category will the lesion fit in? So your management becomes super easy, right? So oral hairy leukoplakia, you don't even have to now think. It has designed your thought process in a way that oral hairy leukoplakia is an indicator of HIV. That comes under the list of non-malignant lesions which are requiring specialist referral. Is it or not like a beautiful way to first categorize your condition into these broad three categories? Your management immediately starts becoming evident. And then the oral pigmentation, which is physiological. One by one, we will work on all these conditions. One by one, we will work on all the non-malignant conditions which require referral. And also individually, we'll take up the red flag conditions which indicate oral cancer, and we'll talk about all of them. All right. So now you know the broad three categories in the entire chapter, right? Now, also you can manage in your general practice is your psoriasis spots and leukodema. They per se do not require any treatment. Agreed? So it can be completely be under your supervision. They do not require any active management. They come into your scope only. You can diagnose them, but there is no active management which is required. They're all physiological. Psoriasis spots are ectopic sebaceous glands, and leukodema also does not require any management. Okay, so when is referral required? When there is a serious oral mucosal condition suspected. So oral cancer whenever you suspect, potentially malignant disorders when you suspect, they require immediate specialist referral. So how would you clinically see and tell it's an oral cancer? Yes, linea alba, it is not physiological, it is slightly pathological, you can say, because it is because of your bruxism, right? So keratinization of mucosa nivedita. But yeah, active management is still not required. It's a physiological change only, excessive keratinization. Now, how would you look at a lesion and tell, oh, it's oral cancer, I should refer? Is there any clear-cut sign? No. All the red flags are basically the oral cancer signs. Agreed? Yes, Priyanka, I have a power session covered and it's included on your program already. The oral cancer, frictional keratosis, and linea alba. How to distinguish between the three. Beautiful class. If you prepare that class, ADC tricks you in the white lesions, and I have given you amazing techniques there to identify those lesions in the exam. Biopsies always, yes. Now, how would you clinically look at a lesion and say that, yeah, this can be oral cancer? So that is your red flag features would be present. Diagnosis would be harder to make. Diagnosis will not be clear. and it would not be responding to any initial treatment. I don't remember the class number, Charmy. If you look in the archive section by white lesions, you would find it. It's one of the important article classes. It's not CV, Fatima. It's not CV. It's another separate lesions. CV also includes cancers, but there was another special class that I took completely on frictional keratosis, leukoplakia, linea alba, and yeah, it's one of the important topics. So now everybody understood red flags would be present, diagnosis would be unclear, and initial treatment response would not be coming. Those are your 3 indicators for referral to the specialist, which indicates oral cancer. So let's talk about what are the red flag features. So red flag features, number 1 is duration, right? More than 2 weeks is your ulcer lasting more than 2 weeks is your red flag. Any pigment that is present which can be indicating of melanoma. So pigmented lesions. Pigmented lesion is also a red flag. Now red, white and mixed lesions with other risk factors like induration, rolled margins, fixation of the tissues from the underlying muscles, and high risk site. These are all again your red flags. Now what are the high risk sites? Lateral border of the tongue and floor of the mouth. These are the 2 extremely high risk sites on the oral cavity. Can you memorize that? Lateral border of the tongue and floor of the mouth. Any lesion which is mixed, red and white, indurated, rolled margins, fixated, and present on these high risk sites. Pigmented, ulcer lasting more than 2 weeks, associated paresthesia, associated nerve involvement, again high indicator of malignancy. Lumps or swellings which include lymphadenopathy, right? Lumps, swellings, even salivary gland involvement. Any swelling, any pain or blockage in the salivary gland. Absolutely yes, Ashley. So they also suggest salivary gland involvement. So they also indicate a red flag. So can you memorize all these red flags? Now these are the red flags. Ulcers which are lasting 2 weeks, pigmented lesions, red, white, mixed lesions with risk features, induration, rolled margins, fixation and high risk sites. High risk sites include lateral border of the tongue and floor of the mouth, facial and oral paresthesia because nerve involvement indicates malignancy, persistent discomfort without any obvious cause, lumps, swellings, and salivary gland involvement. These are your red flags. Okay? Now, the conditions which are non-malignant. So, this is your second category. Your first category was here. Right? This was the first category. You manage it yourself, given that no red flag should be present. This is your second category, any lesion with such feature, any, no matter what is the provisional diagnosis, if any of these present in it, even if it's a traumatic ulcer lasting more than 2 weeks, if it's a traumatic ulcer on the lateral border of the tongue, if it's a traumatic ulcer with some paresthesia, right? Or if it's a traumatic ulcer and there are associated lumps and swellings associated on that area, or indurated margins, or fixated, or rolled margins, that will not be treated as just traumatic ulcer by your practice. You can remove the source of trauma, but immediate referral is needed. So if you have separate options, remove the source and referral, choose referral because the red flag is present. Does that make complete sense for everyone? So far, both the categories completely understood, memorized, yes or no? Now, the third category, which is your non-malignant conditions which warrant your specialist referral, is your recurrent or non-traumatic ulcers. So any ulcers that recur and non-traumatic ulcers in children, dry mouth which is not relieved by over-the-counter measures, and oral signs of systemic diseases like syphilitic ulcer, Behçet's ulcers, HIV. HIV gives you your chronic oropharyngeal candidiasis, where the candidiasis spreads into the pharynx. oral hairy leukoplakia, and then your lichen planus, inflammatory bowel disease, pemphigus, immune compromised patients, right? They all require and warrant your specialist referral. So recurrent aptus ulcer, Tanveer, initially can be treated by general dentistry, the mild form. But if it's your major form, and it is recurring again and again, and your initial management is not working, would require specialist referral. Right? So this is the third category where these are all benign conditions. They're not oral cancers, but they are not treated by you. They are handled by the specialist. Understood, everyone? So which specialist would you refer to? Sometime exam can now give you the options of choosing the specialist. And oral medicine may not be given. Oral medicine specialist may not be on the list. So know the sequence. Oral medicine is preferred. If it's not available, then oral surgeon, dermatologist, and then ENT in the following sequence. Now, these are the three various clinical presentations of oral squamous cell carcinoma. Squamous cell carcinoma on the left ventral surface of the tongue. Is it a high risk site? Absolutely yes. Squamous cell carcinoma on the right anterior ventral surface of the tongue. So because it is confluent with the floor of the mouth, the ventral surface of the tongue, lateral border of the tongue, and floor of the mouth. So ventral surface is practically confluent with the floor of the mouth. So it is one of the high risk sites. Is it not? And then on the left mandibular alveolus. So there, can you identify the red flags here? Can anyone tell what red flags do you see? So red flags are the sites. Red flags are the indurated margins. Can you notice the margins? They are indurated and rolled out. And on appearance, you can say on the middle picture and the third one that they are also fixated. And they are also mixed type, red and white mixed lesion, verrucous appearance, right? So now this kind of picture presents to you in exam. Your likely diagnosis is SCC because of the red flags. Now, what are the risk factors? So one of the concept we learned was if you see any lesion and there is a risk factor present, that will also require you to treat it and consider it as an oral cancer. Did I give you that concept a few minutes ago? If you see a lesion and there are risk factors associated present, you would consider it for management and investigations of oral cancer. Yes or no? Did I give you that concept or not? So now tell me, if in exam you get a picture which is not so evident, like these three pictures are clearly oral cancers because of the indurated and all that, but this first picture is not so evident also. Yes, it has a verrucous appearance, the margins are indurated for sure, but there can be even more simpler looking pictures. But in the history, there can be associated risk factors like male gender, advanced age, smoking or tobacco use, oral potentially malignant disorder like leukoplakia. Your diagnosis could be leukoplakia, so that is also one of the risk factor. HPV infection. If it looks like your HPV infection, that is also related to your cancer. It is different than your behavioral or epidemiological risk factors of HIV, right? So any patient you find HPV related cancer, suppose your patient has oral cancer and when upon born and the cause comes out that it is HPV linked cancer, in those patients you should also test HIV. Okay, understood? Any patient who gets tested in biopsy, now the lesion comes out oral cancer, but it is not your standard squamous cell carcinoma. It's an HPV related head and neck cancer. So that is seen in patients with HIV So that cancer, if an oral cancer is linked with HPV, it should also warrant investigation for HIV, because HIV patients get HPV related squamous cell carcinomas. Okay, this point here, HPV infection, consider HIV testing if HPV related head and neck cancer is identified in a patient. They will not be, but not all the patients will be, Eric, but there are a higher chances. That's why that testing is absolutely mandate to rule that out. Even if they are not showing any other signs of HIV, still you would perform that test. Everybody understood the fourth point here? Then any other history of personal or family history of cancers. If they have had previous cancer therapy, then also it's a risk factor. Any lesion in those patients, you should rule out for recurrence or any other new primary cancer. If there is a prolonged immune suppression, if they are chewing areca nut, betel nut, and if they have UV exposure, because that is a risk factor for lip cancer. Initially, the UV exposure can give a benign condition, which is a pre-malignant potential. Can anyone tell? Sun associated condition, which is a potential pre-malignant condition. Can anyone tell me? And ADC has given you SBQs on that. Absolutely correct, Adarsh. Everyone. Actinic cheilitis it is. So that is why actinic cheilitis, would you require to send the patient to immediately to the specialist, or would you start treating with the lip balm and all those yourself? No, grandfather cannot play with the child daughter. The dad cannot play with daughter. One is the recurrent herpes labialis. That SBQ. You're mixing that one. So father cannot play with daughter is the herpes. He had a very potentially transmissible disease, a viral disease, recurrent herpes labialis. This is actinic cheilitis. It would be seen in surfers. No isolation needed, just no contact, Army. Avoid touching the kids' toys, avoid kissing the child, avoid touching their toys and sharing utensils. Exactly, melanocytic macule. So we have that SBQ in surfers, you see, people who go out in sun, beaches, melanocytic macule, which is the early presentation of actinic cheilitis. Later, you can give sunscreen on the same option, but you have to immediately refer, because oral potentially malignant disorders, actinic cheilitis is a potentially malignant disorder, Priyanka, that requires the lesion to be considered for oral cancer, and management should be done with the specialist. I have showed you that in the ADJ article also. I've done the complete actinic cheilitis article with you all. Remember, it's in a UAF file, this SBQ. And I've shown you the entire actinic cheilitis ADJ article. Remember that. And it had that these cases are best managed with specialist. Anyone here who remembers that case and me showing you the actinic cheilitis article? Anyone here? Charu, you remember, right? And I have shown you the management points there, that these cases are best managed by the specialists because of the higher risk of them turning malignant. Anyone here who remembers that concept as well? Beautiful. So what are the oral potentially malignant disorders? So oral leukoplakia, if your provisional diagnosis is oral leukoplakia, would you send for the biopsy or not to rule out for the specialist referral? Oral erythroplakia, yes. Actinic cheilitis, yes. Oral lichen planus and oral lichenoid lesions. Are they not the non-malignant conditions which warrant the specialist referral? Because specialists will take care that are they responding to the management or not? Do I need to do? And these lesions, OLP and lichenoid are always done. The treatment is started by doing a biopsy. Anyone here who does not know the fact, tell me that. We have done that in Odell case. We have done that in TG3 also. OLP and oral lichenoid lesions. Even the specialists, when they start treating it, they're always confirmed with the biopsy first. All that lymphocytic infiltration under the basal cell. Remember that? classic microscopic view, lymphocytic band, lymphocytic infiltration, the blue band under the basal layer, right? So that classic diagnosis is done with biopsy. So OLP and oral lichenoid is also basically undergoing biopsy. Specialist is doing. Samina, are you enrolled with me? All right. That's okay, Samina. So you will just start doing those ODL cases. Are you in crash course or full course, Samina? So that's great news then. You will do those ODL cases. You will learn those microscopic views. I have covered beautifully in the ODL chapters how to identify OLP, oral lichenoid clinically, and then histological findings and the management. So even the specialists who are treating OLP and oral lichenoid, they are not doing it without biopsy. That means because it is a potentially malignant disorder, that specialists are first taking a biopsy and then starting the treatment. Understood? Now, Samina, even without covering any other chapter now, tell me now, the concept is clear or not? Right? Anusha, it is not covered in crash course because ODL cases are not part of the crash course. Okay? But now, Anusha, did you get the concept now? That OLP and oral lichenoid come under the third category, which is a potentially malignant disorder. I gave you the list, right? The third category, non-malignant conditions which warrant the specialist referral. Is that right or wrong? It came under that category, right, Anusha? Oral lichenoid lesions, oral lichen planus, they came in that third category of non-malignant lesions warranting the specialist referral. So they are also under the conditions of potentially malignant disorder. Now this potentially malignant disorder list anyways puts you at a consideration of considering the lesion for oral cancer. So that again will require specialist referral. And specialists, when they start treating OLP and oral lichenoid, it requires steroid treatment. So they always first take the biopsy, rule out the oral cancer and other conditions, and then start the treatment. Now, does that make sense? Now, we will read more about this in the upcoming class when I take these lesions from ETG in depth. Okay. So don't worry if you haven't done it in ODL case with me. You will do it in these power session series with me. Okay. That's a good news, right? Now, the other conditions which would require is OSMF, which is your oral submucous fibrosis. Then oral lupus erythematosus, which is also a potentially malignant disorder. Diskeratosis congenita, oral graft versus host disease after the bone marrow transplant. These are the conditions when present orally. They can be suspected malignant disorders. That's why specialist referral would be needed. So this can be considered as actually a broader fourth category, which also requires specialist referral. Shall we expand our broad categories to four now? Because this seems like a fourth category to me, right? And actually speaking, all the lesions that come in the exam are one of these categories. Agreed? Everybody. So your initial general dentistry list, red flags, then your potentially malignant disorder is third, and then non-malignant conditions requiring the referral. Yes or no, please? Is everybody up or sleeping? Beautiful. Now let's start with our lesions now, one at a time, and we are going to talk about the oral leukoplakia. So it is a diagnosis of exclusion. Is that correct? It is a diagnosis of exclusion when you have excluded every potential condition. Any white lesion you have ruled out. So frictional keratosis, linea alba, everything ruled out because there has to be a source of frictional keratosis. Now the white lesion class will help you come to the oral leukoplakia beautifully because a lot of people get confused with how to identify oral leukoplakia. Watch the white lesion class. All the crash course candidates also have that class. All the full course candidates also have that class. All the important article classes are included for both crash course and full course candidates. Okay? So oral leukoplakia is a clinical term which is non-removable white lesion, and it is not any specific diagnosis. Therefore, it requires further investigations to rule out other lesions. So after everything is excluded and you can't define a specific diagnosis, that white patch is known as leukoplakia. It can be homogeneous, it can be non-homogeneous. So homogeneous is a smooth one, uniform, but sometimes the surface can be fissured. And non-homogeneous will be more irregular, textural, and even would have color variation, sometimes speckled with redness. They come in the category of oral potentially malignant disorder. Now let's do one thing. Every time we do any lesion now, moving forward in all the 3 series, anytime we move forward, we will categorize the lesion as a broad category. Everybody knows now the 4 categories, right? Let me give you a quick brush up. One category, oral potentially malignant disorder, management we know. Then comes your non-malignant conditions which warrant your specialist referral. Second category. Any condition that includes red flag. Third category. And your general practice conditions. So 4 categories. Everybody understood? So every time now we will do one lesion in our classes in these series, we will start categorizing it. So in the exam, what will happen is you will immediately see the history, you will make a provisional diagnosis, and you will get the immediate broad category. Potentially malignant, non-malignant, red flag conditions, and general practice. Beautifully put, Priyanka. So now some oral leukoplakia can also show some evidence of dysplasia. Dysplasia is mild dysplasia. Then something which is involving the entire layer of epithelium is carcinoma in situ, which has not entered the connective tissue yet. And then invasive squamous cell carcinoma, which has entered, the cancer cells have entered the connective tissue. So there are 3 categories: dysplasia, carcinoma in situ, and squamous cell carcinoma. So this oral leukoplakia, let's put it into category. Everybody, please write down on the list which broad 4 category it will come under. So it is an oral potentially malignant lesion. Absolutely correct. Now, oral leukoplakia is a type of oral potentially malignant disorder, and it is different from your oral hairy leukoplakia. You will not confuse it with oral hairy leukoplakia, which is also sometimes is a white patch. But that is associated and seen with the immune compromised patients. That is why white patches are always ruled out with the underlying conditions. So oral leukoplakia will become a diagnosis of exclusion. That means Epstein-Barr virus related oral hairy leukoplakia is ruled out. Now, OHL, oral hairy leukoplakia, is a misnomer. It doesn't have any hairy projections. It doesn't have any hairy appearance. It's a white patch only, right? But the underlying reason is the immune compromised, and it is not an oral potentially malignant disorder. It is a viral disease. Understood? Yes or no? EBV related oral hairy leukoplakia is a white patch. It is a misnomer. It is not hairy in appearance. It is a leukoplakia only, white patch only, but it is not potentially malignant. It is associated with HIV. So test for that, but do not consider it potentially malignant, and it's a viral disease. All right. Understood? Everybody. Makes sense, right? So now histologically or leukoplakia, when you send it for biopsy, it could be in a dysplasia stage, it could be carcinoma in situ stage, or it could be in a complete squamous cell carcinoma stage. Now you tell me, Tanveer, If you find a white patch and associated immune compromise condition, what that category would be? Non-malignant, not potentially Jasmine, not potentially malignant. I'm talking about oral hairy leukoplakia. That comes in the non-malignant conditions warranting specialist referral. Becomes easy to categorize or not? So management becomes simple or not? Quite easy now, right, Tanveer? So the chances of it transforming into cancer is up to 34%, right? And average is about 3.8%. Early specialist referral for biopsy and monitoring is indicated. Biopsy needed for persistent undiagnosed white patches. That's why immediate specialist referral would be required. Clear for everyone or no? Is it easy or not? Quite easy, right? I do make everything easy. No? Next thing is oral erythroplakia. Now, what category does that come in? Oral erythroplakia. It's a potentially malignant. Now, imagine looking at a candidiasis. Hypothetically, a patient comes, it is a candidiasis, but he says it goes up to my throat. Now, tell me, if it's a candidiasis within the oral cavity, treat it in the general practice, but the patient says it's going up to my throat, immediately becomes your HIV related. No potentially malignant. Jasmine, hold on. So, candidiasis, chronic candidiasis having oropharyngeal component is associated with HIV. That's why it comes under the category of non-malignant but warranting specialist referral. Okay? Going back to highly malignant potential. These are your highly malignant potential. Candidiasis is not in the list, Eric. Priyanka, is it in the list of malignant potential? This is the list. No, take the screenshot. I will create a hot note for this, okay? But this is the list. Take the screenshot if you want. This is your potentially malignant disease. Take the screenshot. Then take the non-malignant condition, right? So immune compromised patients. So oropharyngeal candidiasis. Let me go back to that condition. Oropharyngeal candidiasis is indicating of HIV. So it comes as an oral sign of systemic disease. Yes or no? Tell me, tell me. Right? So this is a potentially non-malignant condition which still warrants the specialist referral. So HIV, oral hairy leukoplakia, and your chronic oropharyngeal candidiasis, both under the category of this oral signs of systemic disease, which is HIV. So this is a non-malignant condition but requires referral for the specialist. Everybody got it or not now? And that is not under your potentially malignant disease conditions, please. HIV related conditions are not potentially malignant conditions. Jasmine, you also confused oral hairy leukoplakia and oropharyngeal candidiasis with that potentially malignant. Now, you would now never forget that they are non-malignant conditions but requiring specialist referral because they are oral signs of systemic disease like HIV. Everybody got it now? So take this screenshot also and then take this screenshot also. Red flag screenshot. This is a third category. And then take this screenshot, which is your basic general dentistry category. And if you take these four screenshots, now memorize them. Okay? Now coming to the erythroplakia. So erythroplakia is a clinical term for potentially malignant. Again, it's a potentially malignant lesion. It's a red colored lesion. It's a red lesion, not a white lesion. And again, a red lesion which does not have any specific diagnosis. So again, just like your leukoplakia, it is also a diagnosis of exclusion. They are asymptomatic, isolated, seen on the floor of the mouth, tongue, soft palate, buccal mucosa. Yes, Tanveer, absolutely right. I will take the screenshots later and post it on the group. Don't worry, guys. Okay? I'll send you the screenshot from these slides. Or I can just upload this slide. I can actually upload this slideshow on the app if you want for your quick revision of this topic. Because this is somehow like a hot note only, right? I'll upload this document. Okay? All right. So I'll upload it under the Winspert Smart Docs. So up to 70 to 90% of the erythroplakia are carcinoma in situ or squamous cell carcinoma. That means this is even higher potential for malignancy or no? An appearance is smooth, velvety, granular or nodular but red in color, and patient profile is middle-aged and older males. And up to 90% it can be cancerous when it is sent for biopsy. So it is extremely high risk. Urgent specialist referral and biopsy is needed. We know it because it's also under our fourth category of potentially malignant diseases. Special monitoring, periodic reviews, repeated biopsies. Early intervention is critical because of its high malignant potential. Absolutely simplified, absolutely now manageable. Is everything coming together, guys? I want to know that it's all beautifully flowing in and you're memorizing concepts as we are going. Wonderful. Now, the last lesion of today's class. Thank you so much, Tanveer. Human papillomavirus related oral lesions, which are your papilloma of the tongue. Now you have to remember HPV can give you two kinds of lesion, benign and malignant, because I just told you a few minutes back, if anyone remembers, HPV related head and neck cancers and HPV related papillomas. They are two very distinct lesions. HPV can cause benign lesions, HPV can cause malignant lesions. When you find HPV related cancers in the mouth, you will send your patient for what testing? HIV. Absolutely. Beautiful. You are listening. Okay? So HPV transmitted, usually it's a sexually transmitted disease, and clinically it shows your small finger-like projections. No. There are two separate manifestations, Eric. Benign doesn't convert to the malignant. Benign is benign, and cancer is starts as a pre-malignant or a cancerous lesion. They are very separate presentations. Benign does not convert to your or transform into your malignancy. So squamous papilloma is the most common HPV lesion. It looks like a finger-like cauliflower appearance. Can you look at the picture and appreciate the cauliflower appearance? Finger-like projections. And it is stalked. Absolutely correct, Sakshi. It's a benign condition. It's sexually transmitted, right? And it can give you oral lesions. When present in the oral cavity, it is called condyloma acuminata. So the oral manifestation is called condyloma acuminata. On skin, it is called verruca vulgaris, which is your common wart. All right. So clinically, condyloma and verruca, they are your HPV related lesions. Intraorally, it's condyloma, and extraorally, it's verruca. And they are clinically very similar to your squamous papilloma. All right. Now, HPV are also recognized as a possible cause for some squamous cell carcinomas. I just told you prior to certain concepts here that HPV is also linked and is a potential cause for squamous cell carcinoma. And it has a site preference as well. You know that? There is a site preference in HPV linked SCCs. So most common sites is posterior tongue, beautiful, tonsillar region, and oropharynx. So if you find a squamous cell carcinoma in the tonsillar region, oropharynx, and posterior tongue, they are likely to be HPV related, and they appear to be distinct entity. They are not SCCs associated with alcohol and tobacco use. So SCC linked with alcohol and tobacco use are separate, and HPV linked SCCs are separate. And HPV linked squamous cell carcinomas are mostly the signs of underlying HIV disease. HPV is a sexually transmitted disease, Priyanka. Okay? So the management is now what category would the HPV come under? HPV would come under is it is the squamous papilloma? Is the squamous papilloma potentially malignant? No, it's non-malignant, right? Red flags may be present, yes. And it could be underlying HIV link also, yes. So referral is still needed. So HPV related benign lesions could have red flag because the sites are the tongue, lateral border of the tongue, right? And also HIV link, right? So that is why referral to the specialist would be required. All right, so that would be it for today's class. I hope all the concepts that we did, the broad categories, and the basic lesions that we did, which is your oral cancer, leukoplakia, erythroplakia, and HPV related oral lesions, both cancerous. HPV related, you have benign as well as the cancerous. So HPV classification, Shashini, would fall under the category of either it would have a red flag, right? Or it would be as a potential systemic disease indicator, which is HIV. All right. Excisional and incisional biopsy. Excisional biopsies you only do for benign lesions. Incisional for potentially malignant. Specialists only do the incisional biopsy. Punch biopsies should not be done when you suspect the malignancy. So any HPV case you would refer. Got that? Everybody. Fatima, can you write your question completely? Chats are going up, so I'm missing that. What HPV? Benign and malignant and head and neck cancer. What is the other? So benign is the potentially non-malignant warranting the specialist referral. Then potentially malignant conditions, red flag, and the general dentist categories. These are the four categories. I don't know, Shashini, what are you referring to? Potentially malignant, non-malignant, red flag lesion needs specialist referral. Yes, potentially malignant, non-malignant, and red flag lesions. All three specialist referral. And the first list, which comes under the scope of general dentist, that without any red flag will be treated by you. HPV will be under non-malignant, yes, or red flag list, depending upon the location. Otherwise, it will be under non-malignant because it indicates systemic diseases, sexually transmitted diseases, right? Yes, yes, Tanveer, it is done. Yes, because when a patient shows sexually transmitted disease, in all the sexually transmitted diseases, you perform HIV testing. So HIV has a list of conditions that indicate HIV testing. You know that? So there is a list of conditions which are known as indicators for HIV testers? No. Specialist Paul. Red flag means referral because it's a higher indicator of malignancy. Red flag itself is not a potentially malignant cause. Red flag is a condition. Red flag is a situation, Navsheen. So it can't be a lesion. Red flag is a situation. So it indicates underlying malignancy, Navsheen. Okay? So I was talking about something. There is a certain list which is known as indicators for HIV testing. Everybody understanding this or not? There is a list called indicators of HIV testing. So your oral hairy leukoplakia, your oropharyngeal long-term chronic candidiasis, HPV infection, or any other sexually transmittable infections, they are considered the conditions or indicators which require testing for HIV. Did I make sense? Oral hairy leukoplakia, chronic oral and oropharyngeal candidiasis, right? Any condition which share the transmission route with HIV. That means any conditions which are also sexually transmitted. They share the route of transmission, right, with HIV. HIV is also sexually transmitted. HPV is also sexually transmitted. What is any other condition that is also sexually transmitted? HSV, right? So all those, yes. Syphilis also. So they are the indicators for HIV testing. Does that make sense now? So when they come under the HIV testing indicators, they come under the category of non-malignant conditions warranting specialist referral, right? As a systemic manifestation of oral manifestation of an underlying systemic disease like HIV. Even tuberculosis. Any patient you find tuberculosis, they are also tested for HIV. Okay? So tuberculosis can give you oral ulcers or not? Can you have oral manifestation of tuberculosis? Does anyone have that knowledge? Yes, it can. Nivedita, it is not as an hot note, but this entire slideshow basically is the notes. So I'm going to upload this document only. Okay, so you can take your screenshots or you can take your prepare from this entire document. All right, so that is it for today. If you have more questions, please forward it to my WhatsApp. And if you have not joined the program, you want to join, please know the crash course includes such classes and even more interesting classes. So not a day will go when you're not learning and your brain is not wide open with information. That's how we prepare. That's how we learn at Winsport. That's my complete dedication to make every chapter and concept super simplified for you all. So please join us if you want to. And if you want to start your preparation for September 26th, we have the dual course option available. A lot of students are joining us for the dual program for the September 26th, and crash course enrollments are also still open. And yeah, thank you so much, guys. Have a great evening. Please forward me more questions, Sakshi, if you have any. Thank you so much, Tanveer. Yes, it has become quite easy now. And when you think of it like that, now on your fingertips, you know all the lesions. Practically, you can close your eyes and you can imagine all the conditions on this chapter. So this chapter seems so huge, but after these power series, you will be like, I can memorize this fingertips. The revision will become so much easier. Yes, next class will be the continuation of this series. We will talk about other conditions, geographic tongue, hairy tongue. and then oral pigmentations, then malignant oral pigmented lesions, and we will continue to categorize it. Okay, we will continue to categorize them in the broader four categories, and we'll start learning the management for the general dentist conditions, because there is one category where you will do the treatment. So not every answer will be simple as a specialist referral. There will be conditions like these oral ulcers, traumatic ulcers without red flags, right? So when red flags are not present, now shingles, herpes zoster, right? It's a viral condition, right? So it comes under the general dentist list, remember? Oral mucocutaneous viral infections. So every lesion that we do, we will categorize it. It will immediately help you. First of all, after completion of this entire chapter, you will feel a hold on the entire chapter. Sometimes you feel so scared of a chapter because you feel it's so vast. How will I remember every lesion? But when you categorize it, it's like creating our own mind map in our mind. Yes or no? We are creating our own mind maps by creating four bigger categories and then that putting it narrower categories and memorizing the individual treatments. So that is how I intend to take entire class, so that you can start memorizing the concepts. It will be uploaded, Jasmine. It will be under the live classes only, no? All the weekly public classes go under the live class only, no? Yes. So you'll find it there. So we will work till next class. We will work till herpes will do, shingles will do. Yeah, till shingles will do. Okay? Next time. This class, next class would be next week on Saturday actually. It would be next week on 27th. So next week on Wednesday and Thursday we won't keep the class because it's the Christmas Eve and the Christmas Day. So we will not keep the class next week on 24th or 25th because a lot of people will be celebrating. So we'll have our internal class on Tuesday, which is UAF2, and we will have our this power session on 27th, which would be Saturday. Okay? And then the Dr. Akers TG class would be on Friday. And then Dr. Anj's Hot Notes revision class would be on 28th. So the class schedule poster will be published on the WhatsApp on Sunday night. Yes, Tanveer, that would be an internal class only, Tanveer. I will plan it. After we finish this series, we will do that. Internally only. I might do it close to your oral when we come to the oral surgery thing. Because if I have to keep it internal, then it has to come after UAF2. So yeah, if we have to keep it internal, then it would be yeah, you can leave me with it. Probably cleft lip, cleft palate, I'll do it in week 19. Week 19 I'll do. Yeah. Actinic cheilitis, where in UAF? Go to the UAF file, Priyanka. Find with the keyword actinic cheilitis. Spellings are correct because here it is not. So either find it in MMF or find it in UAF. Search with the keyword on the drive, you will find it. Because if I want to keep it internal, Tanveer, and if we keep it internal, then it has to be done after UAF2 completion. Otherwise, I can keep it as a public class also. I'll take that call. Okay? All right. Thank you so much. My throat is all gone. Let me rest a bit. And thank you so much. Your brain also needs rest with all that listening and learning and memorizing and categorizing. You did a lot of hard work, mental hard work today. So give yourself good rest. And thank you so much for being the fabulous, fabulous audience that you always are. Take care. Bye bye. I'll see you now on Tuesday, the 23rd December, internally, and we will do our UAF2 class. Okay. Bye bye. Thank you, Tanveer. I try my best and I'm so glad you love it. Thank you so much. No ETG in hot notes. Nikita, what I can do is actually I can maybe just put it as a use this information and combine it as a hot note and put it there, or just put the document there. I'll take that call. Give me a day or two and I'll just put that information for you to learn on app, whether it goes as a separate document or under the ETG hot notes. I think it's better that if I put it under ETG hot notes, right? You want it there for the entire chapter revision? Yes? Yes, everybody? All right. If everybody wants it, we'll put it under the ETG hot notes and not as a separate document. Okay? So give it a 2-3 days and it will be uploaded there. Lesions are already there in the hot notes, but I'll put it as a separate hot note of an ETG oral mucosal chapter. So when you're doing it, it will also give you a revision. Okay? Because this is some information, then the other lesions we have taken from other ADJ articles that has extra information, Nikita. So that information is also important. Thank you. Bye bye, guys. Thank you. I'll see you soon. See you next week. Bye.